In this session, we're going to continue our look at the head and neck. We're going to think a little bit more about the facial nerve. So we mentioned the motor roots of the facial nerve previously, and now we're going to think about the actual course and the distribution of the facial nerve, because it has other functions other than solely supplying the muscles of facial expression. We're also going to think about the blood supply and the cutaneous supply, which means the supply to the skin. So the cutaneous innervation of the head and neck. And then we'll also think about some of the viscera that we find within the head and neck, particularly the larynx. We'll mention the thyroid and the parathyroid glands. And we'll have a brief look at the cervical lymph nodes and Waldeur's ring, which is a ring of lymphoid tissue at the back of your mouth and nasal cavity. Okay, so we'll start up with the facial nerve then. So just as a recap, we can see the lateral side of a face, and here is the parotid gland. What we're seeing here are the motor branches of the facial nerve. So if you remember, there are 5 main motor branches of the facial nerve. So firstly, running up in the temporal region, we call the temporal branches of facial nerve. So all of these that are running up towards the temporal region. We then have running towards the upper part of the cheek, lower part of the eye, we have the zygomatic branches. The sort of lower area of the cheek and around the upper part of the mouth, we have the buccal branches. We then have these branches that are running down along the margin of the mandible, so we call them marginal mandibular branches. And then we have some branches that run down into the neck, which are the cervical branches. And if you remember, the proximity of the facial nerve, the motor division of the facial nerve to the parotid gland is of great importance, particularly in inflammation of the parotid gland or disease of the parotid gland can have a huge effect on the motor branches of the facial nerve and can lead to Bell's palsy and things along those lines. So, as I mentioned, the facial nerve isn't only a motor nerve. That is a huge function of the facial nerve, but it also has some other important functions that are worth mentioning here. Now we'll go into a bit more detail about these specific functions when we talk about cranial nerves in general, sort of what are parasympathetic functions, sensory functions, motor functions, what is secretomotor functions, and things like that. So we will come to that, but we have mentioned the motor branches of facial nerve up to now. So the motor nerves that are going to supply your muscles of facial expression actually arise within the brainstem, and these are lower motor neurons that arise in the brainstem. There will be cortical, and again we will talk about this when we discuss neuroanatomy. But there are upper motor neurons that come from the cortex of your brain, so from your primary motor cortex, and these are going to communicate with lower motor neurons that arise within the motor nucleus of the facial nerve, which is within the brainstem. So if we follow this solid purple line, which is representing lower motor neurons of the motor portion of facial nerve, we can see that it runs from the brainstem and then it runs out via the main facial branch. It actually is going to run through parts of the ear, and it is then going to descend through a little hole in the base of the skull in order to get out of the cranial cavity and onto the face, onto the external surface of the face. So I can actually show you that foramen now. So we have to look at the base of the skull, and we need to look around the temporomandibular joint, so the upper articular area of the temporomandibular joint, if you remember, is the mandibular fossa of the temporal bone. And then if we move just behind that, we find this rather sharp spike of bone, and that's our styloid process. And then sitting just behind there, and actually we can feel it on ourselves if we palpate behind our earlobe, we can feel another large process of bone, which is this lump of bone here, which is the mastoid process. So if I turn now the skull to face the screen, there is the styloid process. My finger is touching there. There is the mastoid process, and we can see a hole between those 2 points. So we call that the stylomastoid foramen. And it's through that foramen that the motor branches, or the motor division of the facial nerve, exit the cranial cavity to get onto the face. So your parotid gland would be sat around here, just on kind of the posterior part of your cheek. So it's the word parotid means next to the ear, essentially. So your parotid gland would be sat just where my hand is here, just in front of the ear, and kind of projecting down towards the angle of the mandible, which is here. So it's just sitting in this region here. Stylomastoid foramen is just deep. I obviously can't show you that on myself, but it's just sitting deep. Let me show you on this side. So the stylomastoid foramen is just here. So just below and deep to your ear. So out comes the motor division of the facial nerve, runs anteriorly, and it is running beneath your parotid gland here. And then from there, it's going to split into its 5 motor branches: the temporal branch, the zygomatic branch, the buccal branch, the marginal mandibular branch, and the cervical branch, just like that. So that's the motor part of the facial nerve. And then we'll mention the other functions. So another really important function of the facial nerve is to do with taste. So it's going to supply a special sensation fibers, so special sensation neurons, to the anterior 2/3 of your tongue, so that we can taste things. It's not the only nerve responsible for taste, but it is the main nerve. So the greatest proportion of your tongue, the greatest proportion of the taste sensation from your tongue is carried by a branch of the facial nerve. And it's this branch here, this green branch. So here's the tongue. If you couldn't tell, there's the tongue. From the anterior 2/3 of the tongue, on both the left and the right, you have a branch called the chorda tympani. And we can follow the chorda tympani, which is this green dashed line here, back to the main branch of the facial nerve. And we'll see that there's a little cell body sitting here because it's a sensory neuron, and we call this the geniculate ganglion. This runs back to the brainstem to a nucleus called the solitary nucleus here. So that's the taste function of the facial nerve. And then we also have another distinct function of the facial nerve, which is a secretomotor function. And by secretomotor, I mean it's going to supply glands which secrete something. So in terms of the facial nerve, it's going to supply some of your salivary glands, your submandibular and your sublingual gland specifically, and also your lacrimal gland, which is going to produce tears. So we need secretomotor fibers to do this. So these fibers, or these neurons, start their journey in what's known as the superior salivatory nucleus within the brainstem. They then emerge via the main facial nerve route, if you will, which is this here. And now we're following the purple dashed line. So we can see that it runs via the main facial nerve branch as far as the geniculate ganglion, and then it's going to split into two. So part of the secretomotor fibers of facial nerve are going to run inferiorly, and they're going to join the cauda tympani nerve, which is also, if you remember, carrying those special sensation fibers of taste from the anterior 2/3 of the tongue. So also running within that nerve, the cauda tympani nerve, we have some secretomotor fibers, which instead of going to the tongue, they're actually going to go underneath the tongue, and they're going to go to a small ganglion. A ganglion is a place where you get cell bodies of neurons. And we're going to have a little synapse here with the postganglionic nerves. Again, we'll talk about this in a bit more detail when we talk about neuro. And from the submandibular ganglion, we get branches, secretomotor branches, which are going to go to the submandibular gland, which sits right underneath the mandible, hence why it's called submandibular. And then the sublingual gland, which sits right underneath your tongue. And actually, if you were to look at yourself in a mirror and lift your tongue up and look in the floor of your mouth, you can see actually quite readily two little ridges that run along kind of laterally from the midline in the floor of your mouth. And along those ridges is where the sublingual gland opens. So it's actually quite superficial, the sublingual gland, and is supplied by secretomotor fibers from the facial nerve. And then if we go back to that division of the secretomotor branches of the facial nerve, we can follow an upper branch now, which runs via the petrosal nerve, or the greater petrosal nerve, or here it's called the major superficial petrosal nerve, to another little ganglion called the pterygopalatine ganglion. And this sits within the pterygopalatine fossa. And the pterygopalatine fossa is actually, I'm unable to remove the zygomatic arch of the temporal and zygomatic bone. However, just beneath it and posterior to your maxilla, you can just see, can you see that sort of long hole there? That's the pterygopalatine fossa. So within there is a ganglion called the pterygopalatine ganglion. So what we have are preganglionic secretomotor fibers from the facial nerve entering into the pterygopalatine fossa, into the ganglion, where they synapse with postganglionic secretomotor fibers. And then from the pterygopalatine ganglion, we get postganglionic secretomotor fibers that are going to go into the nose and to the palate. They supply small glands in there, small mucosal glands. And then we also have postganglionic secretomotor fibers that are going to run up with branches of the trigeminal nerve, which we'll talk about later when we discuss the trigeminal nerve and the cutaneous supply of the face, up towards the lacrimal gland. And if we remember, the lacrimal gland is the gland that secretes lacrimal fluid, which we know as tears. So those are the three functions and the course that the three functional divisions of the facial nerve take within the head and neck. And this is just another image which shows the facial nerve distribution and course from a different angle. So we can see here the main route of the facial nerve leaving the pons. So the facial nerve exits the brainstem at the junction between the pons and the medulla. Again, we will talk about these during neuroanatomy classes. And then, so we call that the pontomedullary junction. And then we enter into the area of the petrous temporal bone via a small foramen called the internal acoustic meatus. So there was our petrous temporal bone, if you can remember that. And then on the posterior aspect of the petrous temporal bone, there is a little small hole there, which is known as the internal acoustic meatus. And your facial nerve enters into that hole and then is going to run through parts of the ear. And then once it's passed through the internal acoustic meatus and it's in the region of the inner and middle ear, it's we can see that little geniculate ganglion, which is sort of a junction where some of these divisions take a detour either to the tongue and the lacrimal gland and the submandibular glands, or in terms of the motor branch of facial, are going to finally run through something that's known as the facial canal and out through the stylomastoid foramen. So there's our mastoid process, there's our styloid process, and right in the middle of the two processes we have the stylomastoid foramen. Okay, so now thinking about the cutaneous nerve supply of the head and neck. So the cutaneous supply, the cutaneous nerve supply to your face is supplied by the three branches of the trigeminal nerve, which is cranial nerve number 5. There are 3 divisions of the trigeminal nerve or cranial nerve number 5, and those are the ophthalmic, the maxillary, and the mandibular division. And if you remember, the mandibular division also has a motor function because it's the nerve that supplies your muscles of mastication, but it also has a very important sensory component as well. And then the rest of your head and neck, so not your face, so we're talking about the back of your scalp and the neck itself, are all supplied by cervical branches that come from the spinal cord levels C2 to C4. So between the trigeminal nerve and those upper cervical nerves, the whole of your head and neck, or the whole of the skin of your head and neck, receives a sensory supply. So imagine if you have an itch somewhere on your face, that is being picked up by one of these branches of the trigeminal nerve. As the trigeminal nerve is split into 3, each of these divisions of the trigeminal nerve are going to supply a different region of your face. So the ophthalmic nerve is going to supply the upper region of your face. It's going to supply your forehead, it's going to supply the upper part of your nose, the upper part of your orbit and around your eye, and like the cornea of your eye and things like that. Then the maxillary nerve is actually going to run through and supply the lower half of your nose and your upper jaw, also your upper teeth. And it's going to supply the zygomatic region and the anterior part of the temporal region. And then you have the third branch, the mandibular branch, and this is sensory now. This is going to run down and supply the skin of your mandible, over the majority of your temporal region, and also your lower teeth will be supplied by the mandibular nerve. Then the posterior aspect of your scalp will be supplied by the second cervical nerve. So C2 is supplying all up here. And then as we move down onto the neck, we have the majority of your neck being supplied by C3. Oh, we can see that better here. And then the root of your neck and sort of where your neck meets your shoulders and your chest is supplied by C4. So that's the cutaneous supply of the head and neck. And it's important that you don't get the cutaneous or the sensory supply to the head and neck confused with the motor supply of the head and neck. So as we've said, the muscles of your face are supplied by the facial nerve, but the skin of your face is supplied by the trigeminal nerve, by the 3 divisions of the trigeminal nerve. And then the muscles of mastication, which are separate again, those are the muscles responsible for chewing, are supplied by the trigeminal nerve, and specifically by the motor branches of the mandibular nerve. So the mandibular nerve is the only division of the trigeminal nerve that has any motor branches associated with it. The ophthalmic nerve is purely sensory. The maxillary nerve is purely sensory. But the mandibular nerve is half sensory and half motor. And the sensory branches are going to supply skin over your jaw. They'll also supply your lower teeth and the temporal region of your skin. This nerve also enters in, or these 3 nerves also enter into your cranial cavity and are going to supply the dura within your cranial cavity, but we'll talk about that in more depth down the line. And then the motor part of mandibular nerve will supply the muscles of mastication. It's really important that you can distinguish between those 3 functional areas. Motor innervation of the face is facial nerve. Sensory innervation of the face is trigeminal nerve, and muscles of mastication are trigeminal nerve via only the mandibular division. And now thinking about the blood supply to the head and neck. So we'll talk about the blood supply to the brain. We look at neuroanatomy. But the blood supply to the brain and the blood supply to the head and neck arise from the same place, so it's hard to completely separate them out. So if we look at the arterial, the biggest artery in the body is the aorta, and it has an arch. This arch lies about the level of the vertebral level of T4 or T5, and from there, from that arch, we usually get 3 branches. We get a brachiocephalic trunk, which later splits into the right subclavian artery and the right common carotid artery. And then we get a left common carotid artery, which is this one. And then we get a left subclavian artery. The subclavian arteries are going to run into your upper limbs and supply the muscles and bones and skin of your upper limb, so your arms and your hands and your fingers. But they are also going to give off some branches that will supply the brain. And again, we'll talk about that when we talk about neuroanatomy. Today, we're just going to focus on these common carotid arteries here. So the right common carotid artery and the left common carotid artery. So the common carotid artery runs up the side of the neck, and it's where you take your carotid pulse from. So when you take a pulse in the neck, it is the common carotid artery that you are feeling those pulsations in. The common carotid artery then bifurcates into two terminal branches. We have an internal carotid artery, and that's going to enter your cranial cavity and supply your brain. So again, we'll discuss that in more detail when we do neuro. And we also have the external, which you can see the cut end of here, the external carotid artery. And that's the artery that we're going to focus on today, because that is going to supply, it's going to give off branches which will supply your head and neck and the structures that we are talking about within your head and neck. So, as we mentioned, the common carotid artery bifurcates or divides into its two terminal branches, the external carotid artery and the internal carotid artery. And as we said, the internal carotid artery is going to supply the brain, essentially, and the external carotid artery is going to supply your face, structures in the neck, stuff like that. And just whilst we're talking about the bifurcation of the carotid artery, there's some sort of, this is more physiological, but it's worth noting. There is a little bulge right at the upper end of your common carotid artery, and at the beginning of your internal carotid artery, and we call that the carotid sinus. So it's a kind of bulging of your internal carotid artery, right at the bifurcation of the common carotid artery. And located right next to the carotid sinus, or this bulge in the internal carotid artery, we have what's known as the carotid body. And essentially these two structures have baroreceptors and chemoreceptors located within them that are going to have an effect on blood pressure or detection of changes in blood pressure and varying levels of oxygen within your blood. So it's like a little sensor. But again, you would talk about that in more detail in physiology. It's just they are anatomical structures in that you can see the bulge of the carotid sinus, and you can locate the carotid body. So now we're going to think about the external carotid artery and its branches and where they go. So there are 8 branches of the external carotid artery. There are 3 anterior branches, starting with the superior thyroid artery, which, as its name suggests, it's going to supply the thyroid gland, but also it's going to supply the upper part of your larynx. We also have a lingual artery, which is going to supply your tongue. And then we have a facial artery, and this facial artery has a really interesting course. It sort of does a loop-de-loop as it crosses over the margin of your mandible onto your face, and then runs up at an angle towards the bridge of your nose, supplying your teeth, your lower and upper jaw, and the skin all of your lips, for example. So that's the facial artery. We then have one medial branch, so we can't see it on here, but it's running into, it's running internally towards your pharynx, and we call it the ascending pharyngeal artery. And then we have 2 posterior branches, an occipital branch, which is going to run and supply the scalp and everything that lies beneath the scalp on the posterior most aspect of your head. And then we also have, and you can just see the cut end of it here, a posterior auricular artery. So another term for your ear is the auricle. So this is going to run behind the auricle of your ear, hence posterior auricular artery. So that will supply things around the ear. And then we have two terminal branches. We have the maxillary artery, which is the biggest of all the external carotid branches, and it gives off a huge number of branches that are going to supply lots and lots of structures within your head and neck. And this kind of, we call it the infratemporal region. It's the area beneath the temporal region, so infra taken from inferior. There's also a very, very important branch of the maxillary artery that is going to supply the dura. So it enters into your cranial cavity and supplies the dura, and it's actually very clinically relevant, and we'll talk about that in more detail in a second. And then the last terminal branch of the external carotid artery is the superficial temporal artery here. And again, you can take a pulse from the superficial temporal artery. So if you were to put your palpate your temple, if you will, you can feel a pulsation, and that is in the superficial temporal artery. So here we are just seeing the branches of the external carotid artery in real life, if you will. So this is a cadaveric image which has been dissected. So here is the common carotid artery, and here is the bifurcation into the internal carotid artery, and you can actually see that the beginning portion of the internal carotid artery is thickened, and that is the carotid sinus. So the carotid body would just be sitting around here where I'm highlighting now, and then this is the carotid body, and then we lose the internal carotid artery as it enters deep into the head and neck, and then runs through the skull into the cranial cavity. And here is the external carotid artery here, and we can see the highlighted branch is the superior thyroid artery here. And then we can also see the lingual branch. And here is the facial branch. So you can see that it does this little loop-de-loop as it comes from the neck onto over the angle, or the margin of the mandible onto the face, and it has this very tortuous path as it runs up towards the nose at an angle. We can't see the ascending pharyngeal artery because that would be on the medial aspect of the external carotid, so I'm afraid we can't see that. You can just about make out some of the posterior branches here. So for example, posterior auricular branch. And then we can see the terminal branches here. So this is this bifurcation here, right in front of there's the ear hole of the external acoustic meatus. We can see the superficial temporal artery running up. So again, if you were taking that pulse, you can put your fingers just in front of your ear on your temple and of the temporal region. You should just be able to feel a pulse. And then running anteriorly, we have the maxillary artery here. And actually what you can see is that really important branch that I was talking about, or that clinically important branch, which is going to enter into the cranial cavity and supply the dura. We call it the middle meningeal artery, and you can see that here just before it actually, we lose sight of it because it enters into the cranial cavity. So the significance of the middle meningeal artery, we can just see that entering the cranial cavity here. It enters through a tiny little hole called the foramen spinosum. So the middle meningeal artery is going to enter through a teeny tiny little hole called the foramen spinosum, and it's just this one here, this tiny little one. Next to this is a large oval shaped one here. That's associated with the trigeminal nerve. We'll talk about that another time. But this tiny one, it kind of looks like if I hold the skull in that orientation, it looks a bit like an exclamation mark with the lengthy bit, and then the dot is the foramen spinosum. So that's where the middle meningeal artery enters into the cranial cavity. So if we look from the internal aspects of the cranial cavity, here we can see the foramen spinosum, and that is really closely associated with an area of your skull. Can you see that? Where 4 bones are coming together: the parietal bone, the temporal bone, the sphenoid bone, and the frontal bone, and we call that area the pterion. So there is a nice view of that pterion. It's essentially where so here is your frontal bone, here is your parietal bone, here's your squamous part of the temporal bone, and here is that small part of the sphenoid bone that goes onto the external surface of your skull, and it forms this almost H-shaped suture, and that's known as the pterion. Anyway, that's our pterion here, and that is a weak point in our skull because we've got these suture lines all coming together. So the temple is the weakest point of your skull. And it just so happens, unfortunately, that running right behind the pterion internally, so here's the pterion inside the circle, and as the middle meningeal artery enters through the foramen spinosum, which is just where I'm highlighting now, it then runs straight across the internal aspect of the pterion. So if you were to have a blow to the head in the region of the temple, because it's the weakest part, there's potential for a fracture to occur here, and this could damage the middle meningeal artery as it runs internally across this pterion, and this would lead to an extradural hematoma. So you get bleeding between the skull bone itself and the brain, because if you remember, I said that this artery is supplying the dura, and the dura mater, again we'll talk about this more in neuroanatomy, but the dura is like a really strong bag that surrounds your brain. So the blood is not getting into your brain, but it can't go anywhere because it's trapped by your skull. So what ends up happening is you get this massive hematoma, or essentially a bruise within your skull, and it actually pushes. So all of this light coloured stuff here is blood, and you can see the margin of it that I've highlighted with this yellow dotted line here. So this is all blood, and then all the darker stuff here is brain matter. So you can see that the brain has been pushed laterally, and if this isn't dealt with quickly, then actually this can be fatal. It's a medical emergency that needs rectifying, and essentially the main culprit, or the most common reason for an extradural hematoma, is damage to the middle meningeal artery. Okay, so then thinking about the venous drainage to the head and neck now. So the main vein where all the blood is running back to from your head and neck, well, there are two. There's the internal jugular vein, which is a massive, relatively massive vein running down the side of your neck. This is deep. This is deep to those muscles that I was talking about, the sternocleidomastoid. So it runs beneath them. So you can't see your internal jugular vein. However, you also have an external jugular vein that runs superficially. So this runs over the top of sternocleidomastoid on the side of your neck. So sometimes if you're out of breath, or you're angry, you can see your external your external jugular veins protruding on the sides of your neck. So those are the two main veins where the branches of your head and neck venous system are running back to. So we have many veins that follow the arteries, so they have similar names to the arteries. So we have, for example, a superficial temporal vein, we have a maxillary vein, we have a facial vein, a superior thyroid vein, a posterior auricular vein, and then we have a few veins that are not named the same as the corresponding artery. So things like retromandibular vein and the angular vein. Now we're going to move on and we're going to have a little think about the thyroid gland. So again, we're not talking too much about function. This is very general because that would come under physiology. But essentially it's going to produce a couple of hormones, so the thyroid hormone and the calcitonin hormone. And these have an effect on your metabolism. So the thyroid artery sits on the anterior aspect of your neck. It's kind of wrapped around the lower end of your larynx and the upper end of your trachea. And it lies deep to some of those infrahyoid muscles that we were referring to last time, particularly sternohyoid and sternothyroid muscles. So as I said, it's lying anteriorly to your trachea and it extends from the vertebral levels of C5 to T1. And it's anatomically, it's split into two lobes, one on the right and one on the left. And they are joined together across the anterior aspect of the upper part of your trachea by this bridge area that's known as the isthmus. And then if we look posteriorly, you can see the left and the right lobes sitting either side of your pharynx. And there's your esophagus here. So the thyroid gland itself sits within a thickened fibrous capsule, and then it's wrapped up in pretracheal fascia, if you remember us talking about fascia last time. So when it comes to clinically important things regarding the thyroid gland, so it has quite a funny development. I'm not going to go into that into any detail here, but it has a kind of an interesting developmental process in that it actually starts its life from the developing tongue, and as the thyroid gland descends from the primitive tongue, what can happen is it doesn't make it to its usual anatomical position between C5 and T1, anterior to the thyroid, anterior to the trachea. You can end up with an ectopic thyroid gland. So essentially it just doesn't descend, so it can lie further up your neck, anywhere between the root of your tongue and down, essentially. Thyroid gland can be removed, so we call that a thyroidectomy. So it might be that there is thyroid cancer or something like that. This can have huge implications on speech. So running very, very close to the thyroid gland, we have the nerves that are going to supply your larynx and allow you to speak. And it can be more critical than that, actually, because there are muscles within your larynx that open your vocal folds to allow air through. So not only does it have implications for your speech, so if those nerves become damaged, you would have a hoarse voice, but also there's potential that if the posterior cricoarytenoid muscle was paralyzed, that you are unable to open your vocal folds and let air in at all. So that would be a very, very dangerous state to be in. So it can affect breathing and it can affect talking. And then also associated with thyroid glands, we have goiters, so enlarged thyroid glands. And again, here there's a risk to those nerves that are supplying your larynx. Now, just a quick mention of parathyroid glands. So these, there's 4 of them usually, and they produce parathyroid hormone. Again, this has metabolic functions and things to do with levels of calcium in the blood and things like that. Again, that's physiology. I won't go into any more detail than that. But there are usually 4 of them, and they are very small, little oval-shaped blobs. And typically, they sit on the posterior aspect of your thyroid gland. This can vary, because obviously, as I said, you can get ectopic thyroid glands, and these actually develop from the thyroid gland and the parathyroid gland develop from 2 completely distinct regions. So what can happen is your parathyroid glands will be in the general region of where you would usually expect to find them, and your thyroid gland might not be there, or something to that effect. So as I said, there's usually 4 of them. You usually have 2 superior ones and 2 inferior ones. So they usually sit on the posterior aspect of the lobes on the right and left of the thyroid gland. And now we're going to have a look at the larynx itself. We're going to think about the laryngeal skeleton. So the cartilages and the one bone that is associated with the larynx. And we'll also think about its innervation and blood supply. So here on this image, on this side, we can see the blood supply to the larynx. So as I mentioned earlier, the external carotid artery gives off the superior thyroid artery. This would be on both sides. You have one right, one left. So these would supply the 2 halves of your larynx as well as your thyroid gland. You also have an inferior thyroid artery, which comes from a little branch of your subclavian artery called the thyrocervical trunk, and the inferior thyroid artery runs up your neck and is going to supply the inferior part of your thyroid gland and also the inferior half of your larynx as well. And then the veins pretty much follow suit, except so you have a superior and an inferior thyroid vein draining the thyroid and the larynx, but you also tend to, and this is typical but not always present, but typically you usually have a middle thyroid vein as well, but you don't have a middle thyroid artery. And then innervation wise, all of the sensory and motor supply to your larynx comes from the 10th cranial nerve, which is the vagus nerve. This is hugely important, so remember this. As I say, there's a lot of implications in your neck, like diseases in your neck and surgeries that happen within your neck that can compromise these vagal branches that supply your larynx and lead to problems with speech and breathing and things like that. So these are critical nerves. So we have, this is the main vagal trunk here, and actually the vagus nerve is running down into your chest and into your abdomen to supply parasympathetic supply to your lungs, heart and gut. But as it does that, it also gives off some general motor and general sensory branches. So superiorly, it gives off the superior laryngeal nerve, which is this here. And this splits into two branches, an internal branch and an external branch. The internal branch is sensory and the external branch is motor. And then further down, and actually all the way in the chest on the left hand side, we have what's called the recurrent laryngeal artery, which is essentially so we had a superior branch, so this would be the inferior branch, but we don't call it the inferior laryngeal nerve. We actually call it the recurrent laryngeal nerve because it completely bypasses the larynx, goes into the upper part of the chest and then branches from the vagus nerve, and then it runs back, so it recurs essentially. It runs back underneath the arch of the aorta and enters back into the neck and ascends up the neck to supply the trachea and the larynx and the muscles of the larynx from below. And the recurrent laryngeal nerve has both motor and sensory neurons running within it. So let's have a little think about the laryngeal skeleton. So we have 3 singular cartilages associated with the larynx, and then we have 3 paired cartilages associated with the larynx. So the 3 singular cartilages that we have, this is a posterior view, this is a lateral view, and this is an anterior view here. So posteriorly, we can see the largest, or on all 3 views, we can see the largest singular cartilage, and that's the thyroid cartilage. So here it is from the lateral side, here it is from an anterior view, and here it is from a posterior view. So the thyroid cartilage has 2 laminae. There's one lamina. A lamina just means a flat sheet, essentially. So it has a flat sheet of cartilage on one side, a flat sheet of cartilage on the other side, which meets anteriorly in the midline, and we call this the laryngeal prominence, or you might also refer to it as the Adam's apple in males. So it is a lot more prominent in males. However, all the Adam's apple is, or the laryngeal prominence as we're now going to call it, is the union of the left and right laminae of the thyroid cartilage, which come together in the midline. So both males and females have it, it's a lot more pronounced in a male larynx than a female larynx. And that has an effect on the tone and the pitch of the voice. And we then have, on the posterior aspects, we have these horns. We have the superior horn and the inferior horn on the right, and a superior horn and an inferior horn on the left. The next singular cartilage is the epiglottis. Here we can see it's a leaf-shaped cartilage, and it's a hugely important cartilage. We can see it from the back side there. We can see it laterally just poking up above. This is the hyoid bone here. And we can see it poking up just above the hyoid bone. And then anteriorly again, you can see it. This is the hyoid bone here. And we can see it projecting above the hyoid bone and running down, tapering down as a leaf would as it attaches to the thyroid cartilage internally. You can see that here. So the epiglottis is really important when we're swallowing. So it's one of the barriers that we have to prevent aspirating food or liquid into our trachea and ultimately into our lungs. And then the third and final singular cartilage that we have is this one, which has a really big plate of plate of cartilage on its posterior aspect. But then if we look from the lateral side and the anterior side, it has a very thin ring on its anterolateral aspects. And we call that the cricoid cartilage. And the cricoid cartilage is the only full ring of cartilage in the whole respiratory tract. All the other cartilages tend to be either C-shaped, so they tend to be deficient posteriorly. You don't get whole rings of cartilage. The cricoid cartilage is the only one that is a complete ring. And it's like a signet ring, so it's kind of thinner anterior and laterally, and then it has this big plate posteriorly. So those are the singular cartilages, and then I mentioned that there are 3 sets of paired cartilages. So we have 2 arytenoid cartilages, they're here. So this is a posterior view, as I said. So this is the right arytenoid cartilage and this is the left arytenoid cartilage. And it's the arytenoid cartilage that actually, so movement of the arytenoid cartilages actually control the opening and closing of your vocal folds. And they sit on the posterior aspect, the upper surface of your cricoid cartilage posteriorly. And then we have some smaller cartilages known as the corniculate cartilages. These sit on the tip of the arytenoid cartilages. And then not shown on here, but we also have some cuneiform cartilages. And essentially the corniculate cartilages and the cuneiform cartilages help to support some of the membranes which are attached around here, around this posterior part of your larynx. So those are all the cartilages or the skeleton of the larynx. So we've mentioned the laryngeal skeleton. We now are going to talk about some of the membranes associated with the laryngeal skeleton. So how is it all held together? The thyroid cartilage has to be held to the hyoid bone, the cricoid cartilage has to be held to the thyroid cartilage and to the trachea. And then we also need some membranes that are going to be covered in mucosa and will be associated with muscles that are actually going to move those arytenoid cartilages in order to move your vocal folds when talking, singing, whispering, and all the differences in those sounds. So I'm going to use this app here, which is called Complete Anatomy. So we can see the larynx here on the neck, and you can see the nice position of the larynx here. And so here's the hyoid bone, here's the thyroid cartilage, and here's the cricoid cartilage. So this is looking from a lateral view. And we can see the laryngopharynx sitting behind here. So holding your thyroid cartilage to your hyoid bone above, we have a thyrohyoid membrane, which is this here. The thyrohyoid membrane has a little hole in it, and as I mentioned before, there's an internal laryngeal nerve which comes from the superior laryngeal nerve, and that's actually going to enter into the larynx through that little hole in the thyrohyoid membrane. And then it's going to supply sensory supply to the internal surface of your larynx above the level of your vocal folds. We then have a quadrangular membrane, which is essentially holding your epiglottis to your arytenoid cartilages. We also have holding the cricocartilage to the first laryngeal ring, the first tracheal ring, we have the cricotracheal ligament. And then finally, and perhaps most importantly, we have, now it's called the conus elasticus on here. That's not what I would refer to it as. I would call it the cricothyroid membrane. They mean the same thing. This happens a lot in anatomy. One structure has several names. So conus elasticus essentially is a Latin name given to, based on the structure of this membrane. However, cricothyroid membrane sounds better to me, just because it's talking about its location and helps you remember where it's attaching to. So that's your cricothyroid membrane, and it's actually the upper part, the upper free edge of the cricothyroid membrane that forms your vocal fold. So the mucosa that runs over that free edge, and there's a little muscle called vocalis muscle within it, which we'll talk about in a second, which form your vocal folds. So important little membranes there. Okay, so looking at the actual anatomy of the larynx and how it looks in life when all of these structures, the cartilages and the membranes, are covered over with mucosa. We can see that here. So we're looking from above. This is the epiglottis here. That's the tongue. That's the posterior part of the tongue, or the root of the tongue. We can see two little depressions either side of the epiglottis there. Those are the valleculae. Sometimes things can irritate the valleculae here, and you have a huge coughing fit. Maybe a little bit of pepper or something tickles the back of your throat. Oh, it's horrible, and that's often something that's irritating the mucosa of your valleculae. So what we're looking at here is this area here behind is the laryngopharynx, and what we can see is there are two on either side. There are two depressions, two little kind of areas of the laryngopharynx that are surrounding your larynx here. Those are the piriform recesses, and again, those are clinically important areas because things can get stuck in those holes. Fish bones and things like that can get stuck into that area, and running just laterally, so just behind here, we have those nerves, those laryngeal nerves, the recurrent laryngeal nerve particularly, and the main branch of vagus, and also those hugely important blood vessels, your internal jugular vein and your common carotid arteries, are running very close to these piriform recesses. So if there was a fish bone, for example, to get stuck within the piriform recess and it poked a hole into your mucosa, obviously there are some very, very important structures running behind there. So that's the piriform recess. And then if we look in the center of the image, this area here, we are looking at the vestibule of the larynx. So that essentially is the upper part of your larynx above the vocal folds. Here are the vocal folds, and the gap between the vocal folds we refer to as the rima glottidis, or just the rima glottis. So that's the hole, and we're looking down into the trachea. So that's the trachea here. That'll go all the way down to your lungs, and these are your vocal folds here on the left and right. So what we can see is that lying above your vocal folds, or the true folds, we have some more folds, and these are the vestibular folds, or the false folds. And then there's a little sinus that lies within there, a little gap between the true, or the vocal fold itself, and the vestibular fold, and we call that the ventricle of the larynx. And again, that has effects on the qualities of the sound that you make when you're speaking or whispering or singing, resonance and stuff like that. Essentially, the vestibular folds are formed by the free edge of the aryepiglottic fold. So here are the arytenoid cartilages, and here is the epiglottis, and we have these folds that run between them, which are overlaying muscles that are sitting within there, and the free edge of those folds is forming the vestibular fold. So now we're going to have a look at the intrinsic muscles of the larynx. So it's these intrinsic muscles of the larynx that are going to move your laryngeal skeleton in such a way that you are able to speak in the way that you do and change the quality of your voice, whether you're singing, whether you're whispering, whether you're talking loudly or talking quietly, or whatever it is that you're doing. These intrinsic muscles are controlling the position of your vocal folds and your larynx. So the first one I'm going to mention is the cricothyroid muscle. So this lies anterolaterally. It attaches from your cricoid cartilage to the lower end of your thyroid cartilage on each side. And essentially what this does is it pulls your thyroid cartilage down towards the cricoid cartilage, which effectively stretches your vocal folds. And the cricothyroid muscle is the only muscle that is innervated by the external laryngeal nerve. So if you remember, I said there's a superior laryngeal nerve that branches off from the vagus nerve higher up in the neck, and that splits into an internal branch, which is purely sensory and supplies all the mucosa above the level of the vocal folds. And then there's one motor branch, which is called the external laryngeal nerve, and it's the external laryngeal nerve which supplies cricothyroid, and it's the only muscle that is supplied by that particular nerve, the external laryngeal nerve. The next muscle I'm going to mention is the thyroarytenoid muscle. So attaching from the internal aspect of your thyroid cartilage, running back to the arytenoid cartilages posteriorly. And when this contracts, it actually pulls your arytenoid cartilages closer to your laryngeal prominence, where this muscle is attached. So it shortens your laryngeal folds, or your vocal folds. And this is supplied by the recurrent laryngeal nerve. And actually all the other muscles that I'm going to talk about now are supplied by the recurrent laryngeal nerve. So all the intrinsic muscles of your larynx are supplied by the recurrent laryngeal nerve, or the recurrent laryngeal branch of the vagus nerve, except cricothyroid, which is supplied by the external laryngeal nerve. So now you can see why damage to the recurrent laryngeal nerve, unilaterally or bilaterally, would have such a profound effect, because all but one of the intrinsic laryngeal muscles are supplied by that nerve. And it's these muscles that are allowing you to speak properly, or produce sound properly. Also worth noting with reference to the thyroarytenoid is the most medial fibres are called vocalis, and these are actually forming your vocal folds, if you will, when they're covered up with mucosa. And then the next muscle we call the posterior cricoarytenoid. So this lies posteriorly on the posterior aspects of your cricoid cartilage and attaches to the arytenoid cartilages. And this is the only muscle that can actively abduct or open your vocal folds. So paralysis of this muscle would mean that you cannot open your vocal folds properly. And again, supplied by recurrent laryngeal nerve. We then have the lateral cricoarytenoid, so also attaching to your cricoid, but this time to the lateral aspect of the ring of your cricoid cartilage, and then to the little lateral process of your so it's attaching to the ring part on the lateral aspect of your cricoid cartilage, and then running to attach onto the little muscular process of your arytenoid cartilages. So this acts to adduct or close the vocal folds. We then have the transverse arytenoid. This runs from the left arytenoid cartilage to the right arytenoid cartilage, straight across in a transverse fashion, which is why it's called transverse arytenoid. And again, this is going to adduct the vocal folds or close the rima glottis. And we also have the oblique arytenoids, which are very similar to the transverse, except they run in an oblique fashion. So they run at an angle to the horizontal. And once again, these act to adduct or close the rima glottis, or adduct the vocal folds. They also act as a sphincter as they run up the side, forming these aryepiglottic folds. They run up the side of the epiglottis and kind of act as a sphincter, again during deglutition or swallowing, to prevent aspiration into the respiratory tract. And remember, all muscles, all intrinsic laryngeal muscles are supplied by the recurrent laryngeal nerves, except the cricothyroid muscle, which is the external laryngeal nerve. And then remember that all mucosa above the level of the vocal folds is supplied by the internal laryngeal nerve, and all the mucosa below the level of the vocal folds, including the vocal folds themselves, is supplied by the recurrent laryngeal nerve. So the recurrent laryngeal nerve is hugely, hugely, hugely important in that it supplies the vast majority of your larynx. We're now briefly going to discuss the lymphatic drainage of the head and neck, specifically the group of cervical and the lymph nodes, the positions of lymph nodes within the head and neck. So This is a more superficial view here on the left, and this is a deeper view here on the right. So there are groups of lymph nodes associated with drainage of the head and neck. We'll start posteriorly here. We have occipital nodes, and you can see the region associated with drainage to the occipital nodes. We then have mastoid or retroauricular, so behind the ear essentially, are associated with the mastoid, which are draining the area highlighted in purple here. We then have parotid nodes, which sit very closely to the parotid gland and are going to drain this region shown in a reddish colour here. We then have nodes that sit beneath our mandible, so we call them submandibular nodes, and that is going to drain regions of the anterior part of the face and even up to the nose, following the facial vein and angular vein. We then have some submental, mental referring to your chin, that's the mental region. So submental sitting underneath your chin, that's going to drain the area of your chin and your lower lip. We then have superficial cervical nodes, which sit, as the name would suggest, superficially. So they are superficial to sternocleidomastoid. Sternocleidomastoid is often used as a landmark for many things. So in this case, the nodes that sit superficially to it are known as superficial cervical nodes, and those that lie deep to sternocleidomastoid and surround the internal jugular vein we refer to as deep cervical lymph nodes. There are also some retropharyngeal, which lie very deep within the head and neck. There's one that in yellow here, one deep cervical node, which is sitting here. And that's called the jugulodigastric node. So if you've ever had tonsillitis and you can feel a swelling in one particular lymph node in your neck, there is one particular node that tends to get swollen if you have tonsillitis. That is your jugulodigastric node. That is draining your palatine tonsils. And I also mentioned some lymphoid tissue that sits in your nasopharynx and your oropharynx, and that forms a ring of lymphoid tissue in these essentially gaping holes into your body. Your mouth and your nose are just massive holes that are allowing anything that's in the air in. So we can actually draw a line and distinguish those parts of the lymphoid tissue that lie in the nasopharynx from those that lie in the oropharynx. So you have your pharyngeal tonsil within your nasopharynx, or your adenoids, you may also have heard them referred to, and also your tubal tonsils. And the tubal tonsils sit around your eustachian tube, so the opening of that auditory tube between the middle ear and your nasopharynx. And then in the oropharynx, we have our palatine tonsils, which are the ones that we know as our tonsils. Whenever we refer to our tonsils or having tonsillitis, we tend to be referring to the palatine tonsils, the ones that sit right at the back of your mouth that you can see either side of your isthmus of fauces, the junction between your oral cavity and your oropharynx. And then on the posterior third of your tongue, you also have lingual tonsil, which is just a lot of lymphoid tissue. It's the bumpy part. If you can look in a mirror right to the back of your tongue, the posterior third of your tongue, it's kind of lumpy in appearance, and that's because of the presence of the lingual tonsils. So we can see them here. I've added in some additional slides that I'm not actually talking about today, but that are no less important with regards to the head and neck. So if you want to have a look through them and read the corresponding parts of the text, please feel free, and that will help build up a complete picture of the head and neck. But that is it for today. Thank you very much.